Assalamu alaikum. I am Dr. Muhammad Jalal, and I will be presenting today the series of lecture from prostate cancer. In prostate cancer, we will start from epidemiology. We will cover risk factors, screening, clinical presentation, diagnosis, and staging. All the data presented here are being taken from Campbell Inwash 12th edition and European Urological Association Guidelines 2021. Starting from the epidemiology, the prostate cancer is the second most malignancy after lung cancer in men worldwide, counting for about 12.76 million new cases and causing 0.35 million deaths in 2018, which counts for about 3.8% of all deaths by cancer in men in 2018. Incidence and mortality increases with age and varies across region and population. Average age at diagnosis is 66 years. In 2018, 12,76,106 new cases of prostate cancer were registered worldwide, representing 7.1% of all cancers in men. Though diagnosis is 1 in 350 men under age of 50 years, it increases up to 1 in every 52 men for ages 50 to 59 years. The incidence rate is nearly 60% in men over the age of 65 years. In 2018, the highest mortality rates were recorded in Central America, that was 10.7% per 1 lakh people, followed by Australia and New Zealand. The lowest rate was reported in the countries of Asia. South Central was 3.3 per 1 lakh, Eastern was 4.7 per 1 lakh, and Southeastern was 5.4 per 1 lakh people. The mortality rises with age, and almost 55% of all deaths occur after 65 years of age. This is the graphical representation. The red one shows the mortality and the blue one shows the incidence. We see that the incidence is more in Australia and New Zealand, but the death is or mortality is only 10.2. And South Central Asia has the lowest incidence and the lowest mortality. Risk factors. Considerable evidence suggests that both genetics and environment play a role in the origin and evolution of prostate cancer. A wide variety of exogenous and environmental factors have been discussed as being associated with the risk of development of prostate cancer as being etiologically important for the progression from latent to clinical prostate cancer. For example, Japanese men has the lowest risk of prostate cancer, but these men, if they migrated or went to the Western countries, they harbor the prostate cancer in higher cases. Age is the most important factor, as with the growing age, the prostate cancer chances have been increased. Family history, metabolic syndrome, dietary factor, hormonally active medication, which are 5-alpha reductase inhibitors, testosterone, and others are inflammatory bowel disease, balding, gonorrhea, smoking, HPV infection. Coming to family history and risk for prostate cancer. If someone has first degree relative, then for all men, the relative risk is 2.48. And for men before the age of 65 years, 2.87, and for men age 65 or older has 1.92 relative risk. If somebody has affected father, he has the chance of 2.35. Affected brother has 3.14. If he has 2+ first degree relatives, the relative risk is 4.39. And if he have second degree relatives affected by prostate cancer, he has the relative risk of 2.52%. Generally, relative risk increases according to the number of affected family members, their degree of relatedness, and the age at which they were affected. Metabolic syndrome. Metabolic syndrome is a group of diseases which contains diabetes, hypertension, coronary artery disease, dyslipidemias, and waist circumference, which is more than 102%. The single component of metabolic syndrome, which is hypertension and waist circumference, have been associated with a significantly greater risk of prostate cancer But in contrast, having more than 3 components of metabolic syndrome is associated with a reduced risk. On a population level, metformin users were found to be at a decreased risk of prostate cancer diagnosis compared with never users. This is only for the metformin, not for other oral hypoglycemics. Obesity is associated with lower risk of low-grade prostate cancer in multivariable analysis, but increased risk of high-grade prostate cancer. Dietary factors. A weak correlation between high intake of protein from dairy products and the risk of prostate cancer was found. There is no association between intake of long-chain omega-3 polyunsaturated fatty acid in prostate cancer, but a relation between intake of fried foods and risk of prostate cancer may exist. Both low and high vitamin D concentrations being associated with an increased risk of prostate cancer and more strongly for high-grade disease. An inverse association of blood but mainly nil selenium levels with aggressive prostate cancer have been found. Selenium and vitamin E supplementation were, however, found not to be affected prostate cancer. Hormonally active medication. Although it seems that 5-alpha reductase inhibitors have the potential of preventing or delaying the development of prostate cancer, this must be weighed against treatment-related side effects as well as the potential small increased risk of high-grade prostate cancer. Hypogonadal men receiving testosterone supplements do not have an increased risk of prostate cancer.
1 minute. So, then in the what are risk factors mostly commonly related with prostate cancer? Anyone from postgraduates, what are the risk factors which are more related with prostate cancer development? Dr. Najam? Dr. Kamal?
So the increasing age is the highest risk factor for the prostate cancer, and second is germline mutation like TRK1 and TRK2. It's also similar to the prostate cancer. Other are the things that discussed by the Dr. Sharma.
From family history, black men versus white conditions.
Repeat, correct.
So age-related factors, as Dr. Kaval said, black men versus Asian and other descent, and these tend to have increased rate of incidence of prostate cancer.
You know why I'm asking because we are just starting the topic of screening, very important topic, and I want everyone should know about the screening of prostate cancer, why it is important in this topic in CA prostate. So if you don't know the risk factors of prostate cancer development, then screening will not be that much understandable. So this is very much important, that prostate cancer develops into the familial, like a familial disease. When there is a one relative positive, then you will have a 3-fold risk of developing bladder cancer, prostate cancer. So most pronounced factor in the development of prostate cancer is family history. And can anyone tell why people are prone to develop prostate cancer when they are being migrated towards the areas or ethnicity where prostate cancer is common? You, Dr. Kamal, you have read the topic.
Sir, maybe due to the dietary modification from there when they change to the region, and secondly, it is familial, not associated with the sporadic.
Though it is familial, but still this is study proven that when people are migrating from the area when there is low prostate cancer risk or incidence, and when they travel towards the area where there is high risk of prostate cancer, they are more prone, and they are study proven developing prostate cancer more commonly than their previous area of living. What can be the
because
factors?
of the environmental factors?
So environmental factors are important, and what are these?
So, for example, if the Japanese men have a high incidence of prostate cancer and they tend to move to higher latitudes in the northern hemisphere, they tend to have increased risk proceeding in the first, second, and so on, third generation of their successive generations, and the risk increases so on.
In same generation, it's seen that prostate cancer development is there. So second most important cause which were present in this presentation was metabolic syndrome. When it's not even completely clearly understandable that is it associated with prostate cancer or not, but most presumptions are related with dietary and metabolic. This can be the cause related with prostate cancer. So we should move towards the topic of screening, Dr. Jalal.
So coming towards screening, what is screening? Difference between screening and diagnosis. Screening refers to testing for disease in healthy asymptomatic population, whereas diagnosis is the identification of disease among individuals with signs or symptoms. The principal goal of screening is to improve overall health outcomes by identifying and treating disease at an earlier stage. Population or mass screening is defined as the systematic examination of asymptomatic men at risk and is usually initiated by health authorities. Who are at risk and who have average and are high risk? This will come in the coming slides. The co-primary objectives are reduction in mortality due to prostate cancer and a maintained quality of life as expressed by quality of life adjusted gain in life years. Despite the common misperception that early diagnosis through screening is invariably beneficial, it also has the potential for harm. Strong evidence indicates that prostate cancer screening reduces the rates of advanced disease at the time of diagnosis. More recent data show that it also reduces prostate cancer mortality. But controversy exists between the balance of benefit and harm. So who should be screened? Men aging 55 to 69 years of age. If a person has age of 50 years, but who are at average risk of prostate cancer and is expected to live more than 10 years of life, he should be screened. Age 45 years for men at high risk of developing prostate cancer. This includes men who have a first degree relative father or brother diagnosed with prostate cancer at an early age younger than 65 years. Age 40 is for the men at even higher risk, those with more than one first degree relative who have had prostate cancer at an early age from 65 years. If no prostate cancer is found as a result of screening, the time between future screenings depend on the results of the PSA blood test. Men who chose to be tested who have a PSA of less than 2.5 nanogram per ml may only need to be retested every 2 years. Screening should be done yearly for men whose PSA level is 2.5 nanogram per ml or higher.
Previous slide पे जाना. So all men 55 to 69 years should be screened. What will be the benefit? Mike ले ले.
We seen there is no added benefit.
So whom should be screened?
Overdiagnosis होगा.
Correct. But is it overdiagnosis or overtreatment?
Overtreatment. Sorry. Overdiagnosis further followed by overtreatment.
So who should be the population which should be screened?
Strong families with prostate cancer should be screened.
People who are at high risk, especially when there is families with positive and other.
First degree relatives when
What other factors are?
if someone in their family died before the 55 years of age.
Life expectancy is expected more than 10 years. Somewhere it is 50 years, somewhere it is 10 years. With healthy lifestyle, it should have so the patient, this is the population of the patient who will benefit from the screening and early diagnosis. If there is no benefit from the early diagnosis by the treatment of counseling or anything else, then there is no need of screening in these patients. Okay, so this is very clear. When you are going to screen the patients, you must see the patient needs it or not. If patient has no benefit from early diagnosis and treatment, then there's no need of screening in these patients. So why there's no need of screening these patients is because if you are screening and that patient comes out to be positive for prostate cancer, there will be anxiety related to the disease, anxiety, depression, and depression-like symptoms. And this will produce much problems in the life of the patients. And this is why it's avoided in the patients when there is life expectancy is less than 10 years. What other points should be considered in this topic of screening? Why we are saying that this will be over treatment? Dr. Abdurrahman.
Sir, when we do the over treatment, we increase the morbidity, so it should be avoided.
Anyone else? Dr. Najam.
It will increase the burden on the healthcare system, and it could be unnecessary.
Omer.
Sir, if life expectancy is less than 10 years, and it will be of no benefit, only on healthcare burden.
Okay.
Because prostate cancer often grows slowly, men without symptoms of prostate cancer who do not have a 10-year life expectancy should not be offered testing, since they are not likely to benefit. Coming to clinical presentation, symptoms during the early stages of prostate cancer, but it's not necessary that these symptomatic men will have prostate cancer, because these symptoms may be due to benign prostatic hyperplasia or other causes of the lower urinary tract. These are difficulties starting to urinate or emptying bladder, a weak flow, a feeling that bladder hasn't emptied properly, dribbling urine after urinating, increased frequency, nocturia, urgency, urge incontinence.
So these are the symptoms of enlarged prostate, and that enlarged prostate may be because of benign enlargement or cancer enlargement and malignant enlargement.
Symptoms during the advanced stage, which are more specific to the prostate cancer: back pain, hip pain, or pelvis pain, which may be due to the metastasis of the prostate cancer into bones, which are the most likely metastatic site for prostate cancer patients. Blood in the urine or semen, unexplained weight loss. Coming toward diagnosis, digital rectal examination. Before the availability of PSA testing, physicians relied solely on DRE for early detection of prostate cancer, but it needs expertise and it has a limited use for screening at PSA level of less than 3.0 nanogram per ml. Most urologists prefer combining both tools. PSA is superior, but combining both detects well. Coming toward prostate-specific antigen, prostate-specific antigen is organ but not cancer-specific. Therefore, it may be elevated in benign prostatic hypertrophy, prostatitis, and other non-malignant conditions. As an independent variable, PSA is a better predictor of cancer than either DRE or transrectal ultrasound. Numerous organizations now recommend using PSA together with other methods of risk assessment, such as family history, race, and DRE findings. PSA is a member of the human kallikrein gene family. It is secreted in high concentrations into seminal fluid and circulates in blood in bound and free form. Serum PSA levels vary with age, race, and prostate volume.
Can anyone tell that PSA in the blood circulates in bound and free form? What are these bound and free forms, and what other forms of PSA can be present into the blood, especially in the case of CA prostate? Dr. Farad? Gone through topic? No? Dr. Shersha?
Globulins, which is, so it is bound to alpha 1 and anti-chymotrypsin and other macroglobulins in combined forms.
So it's not albumin, it's globulin.
The-
Correct. And what other forms of PSA can be expected into the blood?
The
Have
other,
anyone read the topic of PSA in CA prostate from Campbell? How it comes into the blood in CA prostate? What happens? Why it rises into the CA prostate cases? So it's a protein. When it's being synthesized inside the cells of prostate, it naturally comes into the smaller amounts into the blood. But when there is development of cancer, these cells are fragile and unstable, and they lose or they leak the preformed PSA, this protein, into different stages of its formation. Sometimes it is glycosylated, not glycosylated. Sometimes it added with lipids or not added with lipid. But different stages of synthesis of this compound are being leaked from the cells, and they come into the blood. And PSA comes into the blood in CA prostate cases in different forms, in different stages of its synthesis. So that's why there are different forms and different antigens related with this PSA, and they are being researched, used in the screening or diagnosis of the prostate cancer. So actually these cells leak out the synthesizing protein, that is prostate specific antigen. It's not prostate specific antigen if it is completely formed and excreted outside the cell. But when it is under the process of synthesis and comes out into the blood in the form of a preformed PSA, then that will be more specific towards the CA prostate. So this is why this is under the research. And when you study it from the Campbell in detail, you will come to know how you can further use it for the diagnosis of CA prostate.
The interpretation of PSA values should always take into account age of the patient, whether he has UTI or prostate disease, undergone any recent diagnostic procedure, or have any prostate-directed treatment. Numerous variations on PSA-based screening have been proposed to improve test performance, including the adjustment of the PSA level for total prostate volume, which is PSA density, could help distinguish between PSA elevations caused by benign prostatic hyperplasia and those caused by prostate cancer. A direct relationship between PSA density in the chance of cancer has been documented in a PSA density of 0.15 or greater was proposed for having prostate cancer, and they may go for biopsy. Risk of PSA prostate cancer identified by systemic prostate cancer biopsy in relation to low PSA values. If a patient has 0 to 0.5 nanogram per ml prostate specific antigen level, he has a risk of 6.6% to be a patient of prostate cancer in future. If he has 0.6 to 1 nanogram per ml, he has a risk of 10.1%. If the PSA level is 1.1 into 2.0, the risk is 17%. If the PSA level is 2.1 into 3.0, the risk of prostate cancer is 23.9. And if the PSA level is 3.1 into 4.0, the risk of prostate cancer increases to 26.9. So,
in which cancers the prostate PSA does not increase?
in prostate cancer, sir.
Hi, what type of cancers the PSA does not increase? Like as you have said that 0.5 अगर नैनोग्राम है तो 6.6% चांसेस हैं.
Yes.
तो कोई ऐसे प्रोस्टेटिक हिस्टोपैथोलॉजी है जो जिसमें PSA नहीं बढ़ता है?
Small cell.
This is just an exam question, huh?
Small cell carcinoma of the prostate.
Small cell carcinoma और neuroendocrine.
Yes.
या और कोई आप जीएम साहब बताएं.
Totally undifferentiated prostate cancers will not secrete PSA because these cells will be totally different from the prostate cells.
Poorly differentiate cancer, neuroendocrine and small cell में PSA may not increase.
Yes.
As you have very rightly pointed out, and that even with the 0.5 PSA, there is a possibility of having prostate cancer. तो इसमें फिर इसको improve करने के लिए जो है ना वो DRE must है 40 years के बाद.
Yes.
ठीक है. और on the DRE, if there is a suspicious of nodule, then we should go for trust guided biopsy.
Yes.
Thank you.
Thank you. Biomarkers in prostate cancer, which are blood-based prostate health index test combining free and total PSA and the two pro-PSA isoforms. 4 kilocrane score test measuring free, intact, and total PSA and kilocrane-like peptidase 2, in addition to age, DRE, and prior biopsy status. ISO-PSA utilizes a novel technology which focuses on the structure of PSA. Urine-based biomarkers are prostate.
Sorry, ये पीछे वाले. असर साहब ये जो हम we were doing some work on PHI in detecting the CA prostate.
जी सर, ये एक प्रोजेक्ट प्रपोजल थी सर.
हाँ.
और डॉक्टर महनाज की थी. डॉक्टर नकी साहब earlier has agreed to it, but later he backed out.
Okay.
तो काम हो नहीं सका सर.
इस पे नहीं हो सका. Right. ठीक.
The role of imaging in clinical diagnosis, TRUS and ultrasound-based techniques. New sonographic modalities such as microdoppler, sonoelastography, contrast-enhanced ultrasound, or high-resolution microultrasound provided promising preliminary findings, either alone or combined with so-called multiparametric ultrasound. The contrast used in ultrasound-based tests are different from the CT or MRI-based. The contrast used in ultrasound-based tests are actually bubbles of gases, which has more echogenicity as compared to tissue which have been studied.
So sorry, ये जो है, what are the findings of transrectal ultrasound in cases of CA prostate? हम जब ट्रस्ट करते हैं तो उसमें क्या फाइंडिंग मिलती है हमें प्रोस्टेट कैंसर में?
साइज मिलता है सर प्रोस्टेट का, कि साइज उसका कितना है और उसके लोब्स कौन से लोब्स उसके इनलार्ज है, होमोजेनिसिटी हमें मिलती है उसमें सर, जो हम देखते हैं ट्रस्ट अल्ट्रासाउंड में.
Actually, these are the basic things, but we should all be knowing from examination point of view. डॉक्टर जीएम इस पे जरा ट्रस्ट जब कराते हैं तो हमें क्या एक्सपेक्ट करते हैं कि हमें मिलेगा अल्ट्रासाउंड फाइंडिंग्स पे? Maybe small, but I think we should all be knowing it.
When we are doing ultrasound rule out any nodule or cancer, so nodular enlargement of the prostate will be more related with the cancer of the prostate. Apart of that, we can see the complete anatomical structure of the prostate, in which any altered texture or presence of abscess, hypoechoic lesions or hyperechoic lesions, these all will have different diagnostic values, and complete or proper measurement of the prostate size and volume will be clinically relevant.
Right. So it can be hypoechoic area or can be hyperechoic area.
Yes.
ठीक है, उसकी अपनी इम्पोर्टेंस है. कितने परसेंटेज में hypoechoic होता है ऑन ट्रस्ट, कितने में hyperechoic होता है. लेकिन असल साहब इस पे हाँ
सर 70% के अंदर हाइपोइकोइक होता है, 80% में ट्रांजिशनल में होगा तो वो हाइपरइकोइक होगा.
सही. तो ये इम्पोर्टेंट है कि मतलब ये है कि जब हम कोई चीज सजेस्ट करते हैं कि इसका ट्रांसरेक्टल अल्ट्रासाउंड कराएं तो क्या एक्सपेक्ट करते हैं हम लोग. तो दिस इज व्हाट आई वांट टू share with you that these things should be known by us, all of us, as a
Yes.
as a student of FCPS or as a consultant, कि हम क्या एक्सपेक्ट करेंगे कि जब ब्रश कराते हैं तो क्या एक्सपेक्ट करते हैं कि हमें मिलेगा. तो उसमें हाइपोइकोइक एरिया भी हो सकता है और हाइपर इकोइक एरिया भी हो सकता है. तो फिर देन देयर इज अ स्ट्रांग इंडिकेशन फॉर बायोप्सी इन दोस केसेस. अच्छा साहब क्या सर?
जी बिल्कुल, उसमें तीन जो है ना सब एरियाज आप डिफाइन करते हैं व्हेन यू डू एनी काइंड ऑफ अल्ट्रासाउंड, वेदर इट इज per abdominal ultrasound or transrectal ultrasound. But since the probe in transrectal position is very near to the prostate as compared to the transabdominal, so it has got a high resolution of picking up the cellular densities in a given area. So you can have three different kind of echogenicities. One is isoechoic, the other is hypoechoic, the third one is hyperechoic. All three are not without any kind of abnormality, but the isoechoic position is something which is like normal. So if you happen to have say BPH, then it is isoechoic. But if you have got carcinoma or something which is related to infection, perhaps, then it is either hypo or hyper. So whenever, for instance, if there is chronic infection, then it becomes hyperechoic, since there is a little bit of calcification and corpora amylacea can be there in a little bit of increased amount. So these are the findings whenever they are present together with an increase in PSA value, then you always try to figure out whether you want to have a biopsy of the prostate or not. But the interpretation has to be with the clinician rather than with the radiologist. So Mandu Sahab is very right that we all must know what is the picture that is being produced by any kind of technique that is prescribed by you yourself in the clinic. उसको पढ़ना आना चाहिए, कम से कम salient features उसके.
Right, ठीक है. Thank you.
Thank you, sir. Multiparametric MRI has good sensitivity for the detection and localization of International Society for Urological Pathology grade 2 or more than 2 cancers, and MRI is less sensitive in identifying ISUP grade 1 prostate cancer.
ISUP क्या है?
International Society for Urological Pathology.
So is this multiparametric MRI available in Pakistan?
सर उसमें दो तीन चीजें हैं. मसलन बहुत सारे लोग क्लेम करते हैं that they are doing multiparametric MRI. For instance, AKU is one of those centers. But actually, the higher Tesla is needed for a multiparametric MRI, and there are 4 kind of parameters. On that, you calculate a score, and that is a pyrite score. But nowadays, any kind of MRI which is like 1.5 Tesla is being used without the endorectal coil, and you have got reports from everywhere कि जी इसका pyrite 2 है, इसका pyrite 3 है. So it is a wrong interpretation of the technology. The technology is still not available. It should be available, but again needs a lot of investment. So we can have it in our unit also in SIUT, but the thing which is missing from our radiologist colleagues, I come to know, is the endorectal coil. Since it is not with the machine, so we can't go over that. Plus the Tesla. It has to be greater than 3 Tesla, I suppose.
Baseline biopsy. The need for prostate biopsy is based on PSA level, other biomarkers, and are suspicious DRE and are imaging. Age, potential comorbidity, and therapeutic consequences should also be considered and discussed beforehand. Risk stratification is a potential tool for reducing unnecessary biopsies. Limited PSA.
Risk stratification tools क्या हैं ये?
आने वाले स्लाइड्स में आ रहा है.
आने वाले हैं, ठीक. क्योंकि ये जो भी हम बात कर रहे हैं ना, तो हमें पता होना चाहिए कि क्या बात कर रहे हैं. इसलिए मैं बार-बार आपसे कह रहा हूँ, ताकि हमारे जो पीछे बैठे हैं उन लोगों को आइडिया हो कि रिस्क स्ट्रेटिफिकेशन की जब बात करते हैं तो व्हाट डू वी मीन बाय दैट.
सही है सर. वो अदर आगे स्टेजिंग उसमें आ रहा है. Limited PSA elevation alone should not prompt immediate biopsy. Prostate-specific antigen level should be verified after a few weeks in the same laboratory using the same assay under standardized conditions. That is, no ejaculation, manipulations, and UTIs. Empiric use of antibiotics in an asymptomatic patient in order to lower the PSA should not be undertaken.
और जो हम लोग देते रहते हैं सर साहब ये चीज क्या ख्याल है?
बिल्कुल हम लोग करते हैं सर और फॉर इंस्टेंस we don't rely on the first PSA value. We don't jump on to do
Biopsy.
straight away biopsy. For instance, those patients who have got PSA between 4 to 10 nanogram per ml, earlier we were using that same sample for a free and total PSA. But now that concept has been a little bit overruled. And now we repeat the PSA value after having a short course of antibiotics. And that is like 3 days. Now you can read many articles. Some of them use 2 weeks of empiric antibiotics and then they do PSA value. But the practice has been different in many parts of the world. What we are practicing here is actually what the Americans are doing. For instance, if they have got a patient who is on catheter, who is a diabetic patient, who has got a history of recurrent UTI, then that patient should have a longer course of antibiotic. Otherwise, the patient should be with 3 days of antibiotic and then you can use the PSA sample as second
Can
sample.
we ask Dr. Jim, what about in the AUA guidelines on this? If the PSA is raised, should we give antibiotic to reduce that PSA and then to repeat or not? Should we be doing this practice?
Definitely, sir. When you see your own clinical area, I totally agree with Professor Satsab that we are living in the region where infections are more common than cancers. And when we are receiving a patient in our setup and patients have some symptoms, we primarily think about the infections, not the cancers or other diseases like metabolic and these. Like in developed countries, things are different. People initially think of other diseases, then after all these diagnoses, they come towards the infection. So our practice is perfect. When we are dealing with infections more, then we should do it like a practice. And this is guideline also tells it that when there is suspicious infection and PSA is borderline raised, not too high, then we have to go through treating infection first, and but not that like empirically we have to rule out by culture and a specific antibiotic and then treat it and then repeat PSA.
No, जैसे डॉक्टर साहब लिख रहे हैं ना ये कि empiric use of antibiotic is in an asymptomatic patient in order to lower the PSA should not be undertaken. तो ये AUA guideline है या EAU guideline है क्या? EAU guideline है.
इसको तो सर इस स्टेटमेंट को मैं रिफ्यूट करूंगा.
अच्छा.
आई एम अगेंस्ट इट बिकॉज दिस इज नॉट द प्रैक्टिस दैट वी डू हियर.
We do here, yeah.
Plus, this is not the practice that they do in America also. So it is somewhere in between. For instance, if the PSA, आपका ये वाला statement लिया जा सकता है for a PSA value which is maybe greater than 100. But if it is like between in the gray area, so you have to do something for the PSA. We are not doing antibiotic therapy to lower the PSA. We want to increase our suspicion whether this PSA is indicating us to go towards biopsy or not. तो दो philosophies different हैं. इस statement से आपके message गलत जा रहा है. इसका message ये जा रहा है कि शायद आप treat कर रहे हैं something which is like a PSA. You are not treating PSA. You are treating patient. You are increasing the yield of biopsy. अगर आप PSA की वैल्यू नंबर 1 और PSA की वैल्यू नंबर 2 आफ्टर एंटीबायोटिक थेरेपी दोनों को कंपेयर करके फिर आप डिसीजन लेते हैं बायोप्सी का, then your biopsy would be a better biopsy yielding more better result, positive result rather than a biopsy which is taken on one PSA value. That is my impression.
अच्छा दूसरा जैसे ये लिख रहे हैं ना कि limited PSA elevation should not be prompt immediate biopsy.
Yes.
So इसका क्या मतलब है? मतलब आपके ख्याल में अगर PSA बढ़ा हुआ है तो इमीडिएटली बायोप्सी नहीं करना चाहिए ना, यही मकसद?
Yes, sir.
Sir, actually, when PSA rises because of manipulation or infection, this rises within limited elevation.
हाँ,
But in serum, in prostate cancer, PSA rises so high that if there is very high rise of serum PSA, then we will strongly consider that this is prostate cancer. But in between, like rising to 15, 20, our PSA density is just rising from 0.15 to 0.5 or 1, then this can be considered and treated first, and like treating UTI and giving some time to manipulation and then repeat it after 2 weeks.
तो इसका मतलब ये हुआ कि हमें डेंसिटी करना चाहिए या
Yes, sir.
फ्री एंड टोटल PSA का करना
Yes,
चाहिए, उसके
sir.
बाद डिसाइड करना चाहिए, ये
Yes,
मकसद है
sir.
इसका?
PSA divided by volume of the prostate.
ठीक है।
यानी आजकल जो हम लोग कर रहे हैं ना सर प्रैक्टिस, वो किसी वैल्यू के ऊपर बायोप्सी नहीं कर रहे, किसी भी वैल्यू पे, जब तक कि उसकी डेंसिटी ना देख लें।
डेंसिटी ना देखें कोई। सो जस्ट मैसेज ये है कि अगर PSA एलिवेटेड है, दैट कैन बी एलिवेटेड बिकॉज ऑफ अदर थिंग्स रादर देन द CAP। तो उसके लिए जरूरी है कि एक तो UTI को एक्सक्लूड करें जैसे आपने कहा है, और अगर DRE किया है तो उसमें भी एलिवेट हो सकता है, या PSA डेंसिटी कराना चाहिए।
Yes.
PSA डेंसिटी या जैसे आप फ्री एंड टोटल PSA की जो PH जो प्रोस्टेटिक हेल्थ इंडेक्स है उसको भी प्रैक्टिस में लाना चाहिए ताकि अननेसेसरी बायोप्सी शुड बी अवॉइडेड।
Yes.
ये मकसद है ना उसका?
Yes, sir. वो previous slide में
जो ऊपर जो आपने लिखा है।
Yes.
फॉर इंस्टेंस मैं एग्जांपल दे दूं और हमारे जूनियर कॉलीग्स के लिए भी, एक 100 ग्राम प्रोस्टेट है एंड द PSA वैल्यू इज 10. So if you mask yourself from 100 gram prostate and you concentrate on PSA value 10, then you go straight away towards biopsy. But you take into consideration something like PSA density, then the density of this kind of patient is 0.10,
Yes.
which is not indicated for biopsy. So the biopsy indication occurs after the PSA density goes beyond 0.15. So चीजें बदल जाती हैं, आपको बहुत सारी चीजों को ना देख के फिर डिसाइड करना है, बिकॉज आपसे तो यहाँ कोई नहीं पूछ रहा, लेकिन बहुत सारी कंट्रीज के अंदर you have to have a little bit of discussion with the patient because you are actually interfering, invading into the patient.
Yes.
So that needs a little consideration.
Exactly, sir. But when we have seen some of our exam candidates have reported that I'm failed because I could not explain why we have prescribed or advised serum PSA test in the patients during Viva. So knowing very concisely that why we are doing it and how to interpret it, and knowing everything about these things is very much important.
Very much important.
नहीं, दूसरी बात GM, एक चीज तो ज़हन में सबके होने चाहिए, we are here not to pass the exam, we are here to be with the science, and the science changes every minute, right? तो आपके सामने एक बड़ा है एस्पेक्ट ऑफ your own life as a clinician, not just 1 hour exam. इससे आप इख्तिलाफ करेंगे खासतौर पे शुआ, लेकिन this is what the actual meaning of life is. It is bigger than 1 hour.
चलें आगे।
Ultrasound guided biopsy is now the standard of care. Prostate biopsy is performed by either the transrectal or transperineal approach. Some evidence suggests reduced infection risk with the transperineal route. TURP should not be used as a tool for cancer detection.
Anybody from the postgraduates have read guidelines of 2021 regarding this prostate? What type of biopsy is now recommended as an initial tool, and why? Why? Dr. Shah is not PG postgraduate, but still answer is accepted. Now explain.
So in 2019 and 2020, the results of the RCTs were comparable between the transrectal and the transperineal biopsies. But we have an update, and the yield of the transperineal biopsies is much better than the transrectal biopsies, according to the latest evidence shown in the 2021 guidelines. And if I'm not wrong, the figure was around 17 or 18%, having more yield. And the reason behind this is, as we all know, the technique, number one, the approach by which we are taking the biopsies, and number second, the number of the cores we are able to take. As per I know, even in SIOT, we are doing about 30 or something nearer to this amount of cores. And the concern was the infection. Previously, it was not favorable because people say that there was a higher infection rate in the case of the transperineal biopsy, but that has been ruled out as well. Even the infection rates are comparable between the transrectal and the transperineal biopsy. So it is the standard of care at the moment.
And other thing is
multiparametric MRI, as Dr. Asad clearly mentioned, and he has rightly pointed out the kind of multiparametric MRI. I would like to give the example of the patient we have in our exam last month. That was from that particular MRI was from Liaquat National Hospital. And according to the report, it was a multiparametric MRI. But if we look at the films, for my junior colleagues, as Dr. Asad mentioned, there were 4 parameters in the multiparametric MRI. And we know that there, with the usual traditional teaching, we know that there is the loss of hyperintensity in the peripheral zone, which was the hallmark of the CA prostate. And for this multiparametric MRI, we have diffusion, dynamic contrast enhancement, we have ATWG images, and then we have the routine images as well. So it basically based on the Brownian motion we all have read in the physics in 9-10 or inter classes. If we look read again those Brownian motion concept, we will easily able to interpret these kind of parameters. But for that particular scan, which was presented with the patient and when taken to the exam as well, even after exam, we have discussed that with our own radiologist, Dr. Ahmed Lalwani, that was not a multiparametric MRI. But the radiologist reported it as a multiparametric MRI and even mentioned the pirate score as well. So this is the thing going on and we have to face this as well. But I don't think so any examiner will emphasize or suppress on such. But we should know about multiparametric MRI because it is the standard of care. And for biopsy as well, we know there are 2 types. Those who go through the guidelines, there are the cognitive and there are the image guided. Like you give the command to the machine and it will identify the areas and take the biopsies. But and in other case, you will identify the areas yourself and then take the biopsy from that particular area. And there are other concepts like saturation biopsies and then targeted biopsies. And when you go through the guideline, you will come to. So these are all the things available.
So saturation biopsy kya hai or fusion biopsy kya hai?
The fusion biopsy is if I'm looking some like now this, as I mentioned, there's a standard of care that do a multiparametric MRI. If it's a version, sorry,
with trust. If you combine the multiparametric
we were discussing
trust.
So trust, we were discussing DRE and trust as well. As you were mentioning about the DRE, yes, DRE is a tool. And for clinical staging, it is still the prostate staging is dependent on the DRE. But from the literature point of view, there is approximately the figure mentioned is about 1% is the understaging and 11% is the overstaging. If we just apply these parameters, and if we correlate with our trust, the significance of trust is correlating with the DRE. If I'm getting a nodule or something like on my clinical examination and I'm getting the same result on a trust, then definitely it is a high yield. Otherwise, these heterogeneous and hypoechoic and hyperechoic area, like hypoechoic area is in the abscess as well, and hyperechoic in the infections as well. So it is not like hallmark of CA prostate if you found these areas on the, but definitely if it is a nodule, then definitely it is significant. For multiparametric MRI, if you're talking about the fusion biopsy, this is the same thing. Like if I'm identifying some area in the peripheral zone and then I'm targeting that particular area, either by giving command to the machine or by doing it myself cognitively identifying the area, then this is known as fusion biopsy. I'm imaging and the the technique is combined here. Saturation is
Basically, you fuse two images. One is the MRI image,
and
and the other one is the ultrasound image, and that is the truss. But again, the biopsy is truss guided, which is ultrasound guided. You can have this fusion, but the biggest and that debate is not resolved. Was with fusion biopsy, you have got only one or maybe two cores of the tissue which you get for Gleason score. Now for Gleason score, you must have a lot of different kind of cores, probably 10, 12, maybe more, in order to have a proper scoring, proper mapping of the prostate. So the concept now is to have a fusion biopsy combined with a systematic biopsy. If you want to have a proper yield, otherwise you will be missing maybe 10 to 12% of the tumors. So fusion biopsy with a single core might lead to some kind of a mislead in your diagnosis. So again, fusion biopsy is not the ultimate. आजकल ये वाली कहानी चल रही है. अभी टाइम देख लें.
लास्ट स्लाइड दिखाते हैं उसको.
कुछ कह रहे थे बिलाल साहब?
लास्ट पॉइंट पे
लास्ट पॉइंट वाला अच्छा है.
अच्छा, बच्चों के लिए कौन सा लास्ट पॉइंट?
Next slide. So for TRP, it's mentioned if you are found a cancer on the TRP specimen.
Why it is not a tool for cancer?
Because we are unable to re-stratify the patient on these samples, so we need a 10-12 core biopsy even after that.
And that has got a practical implication. For instance, if you are in a prostate clinic and the person is coming to you for follow-up after TURP, and the report is saying that there is adenocarcinoma prostate, but that is not the information that is enough. You have to ask for a systematic biopsy, either transrectal or transperineal, just to not only quantify but also qualify the disease. Sometimes it will give you something which is more than that.
One thing that is that the tumors are found in the peripheral zone. Missing the tumor when you're doing TRP. The patient might have tumor, but you end up missing it because you didn't reject the peripheral zone in your TRP. You were rejecting the transitional zone. So it is not a tool for.
असद साहब जो पॉइंट कर रहे हैं वो ये है कि अगर इन द केस अगर TURP पे बायोप्सी आ जाती है तो भी रिपीट करने की जरूरत है. दिस इज व्हाट वी मीन. अगर TURP पे बायोप्सी पॉजिटिव है, then even then we should repeat the trust guided biopsy. This is what your message is.
I would like to ask Professor S for further clarification in this, because sometimes you are doing TURP and the patient is not in the performance score system shows that patient is not that much good for the invasive treatments, and in that case the patient will not have much benefit from the doing trust biopsy after we have diagnosis on TURP. Then still we will need biopsy to confirm the full volume of the disease.
It's not the volume of the disease. For instance, you want to map out and you want to have a Gleason score. For instance, if you happen to prescribe to the patient that the person needs a radical prostatectomy and the Gleason score is 9, then you are at a fault, right? You are actually standing on a fault line. You have a lot of criticism because your decision is not correct. So anything on a higher scale, higher grade, उसमें प्रॉब्लम आ जाएगी ना आपके ऊपर. तो ये उस वक्त होगा कि जब आप उसको प्रॉपर्ली सिस्टमैटिक बायोप्सी करेंगे. लेकिन अगर आपने सिर्फ पेशेंट है, आपका 90 years एज है, 80 years एज है उसकी, where you don't want to go beyond a certain in terms of management. Even a description of adenocarcinoma prostate is enough. और उसके बाद आप कर सकते हैं वो तो ये तो आप कर सकते हैं, लेकिन मैं तो एक जनरल रूल बता रहा हूँ. पेशेंट टू पेशेंट वेरी करेगा ये.
Exactly, when I was reading this, same as you told was the concept. When there is no life expectancy beyond few years and you are not able to carry out invasive treatments, then it will be enough that you have just to diagnose.
जी जी बिल्कुल.
This will be enough. ये जो है TURP. लेकिन ये है कि अगर कोई रेडिकल ट्रीटमेंट आप प्लान कर रहे हैं तो then there is a need for repeat biopsy even if it is positive on TURP. This is what is the message is?
No, when there is indication, then you will repeat biopsy because this is once invasive thing which we are performing on the patient. Once is negative, then
GM invasion तो हो गया ना, अब TURP कर दी, इससे बड़ा invasion और क्या करोगे?
Not in TURP but in our topic of repeat biopsy.
क्या करके मिलेगा आपको? आपको तो बायोप्सी मिल गई ना, सो MRI तो आपको मजीद बताएगा कि उसने एक्स्ट्रा प्रोस्टेटिक टिश्यूज को कहाँ तक इन्वॉल्व किया, वो तो क्लिनिकल प्रेजेंटेशन है. नाउ दिस इज अ पैथोलॉजिकल प्रेजेंटेशन, सो यू हैव गॉट द पैथोलॉजिकल डेफिनेशन. सो बात कुछ और मंजू साहब कहना चाह रहे थे, वो ये कहना चाह रहे थे कि भाई आप कहाँ पे जाके ना सेटिस्फाई होंगे, तो हमेशा सेटिस्फाई वहां पे हो जहाँ आप पेशेंट को ट्रीट करना चाह रहे हैं. जिस हद तक अगर पेशेंट की एज और उसकी दूसरी कोमोर्बिडिटीज कुछ और हैं,
सही है. तो मतलब ये है कि जैसे जो चीज जैसे आप कह रहे थे ना कि TURP के बाद जो बायोप्सी है तो उसको एक्सेप्ट मतलब उसको रिपीट करना चाहिए क्या? तो एक्चुअली वी शुड बी क्लियर व्हाट रिपीटिंग इट, although there is a concrete evidence that there is a CAP, but in which cases we would like to repeat it. ये हमें पता होना चाहिए, क्लियरिटी होनी चाहिए, खास करके हमारे जूनियर्स को. ये पॉइंट था.
यस
ठीक है ना?
टाइम देखें, टाइम में काफी हो.
ठीक है, थैंक यू.
ठीक है, थैंक्स.